Great to see everybody. Many folks joining. We'll go ahead and jump in. I'm the director of the Abramson Cancer Center, and I want to welcome all of you to Breakthroughs in Action. It's a great chance for us to see how the pilot grants and the funds raised from the Breakthrough Challenge are being used. I want to thank all the board of directors for Breakthrough Challenge. I know Bo is here, and Bill Barber will have a few words to say at the end. I want to thank all the sponsors. You saw if you were in the waiting room, you saw the list of those incredible sponsors going by. Special call out to the Zent Family Foundation. I think Chuck may be tuning in as well. The Breakthrough Challenge is entering its 12th year. This September will be the 12th year. So in the past 11 years, an amazing $2.8 million of funds have been raised and sent over to the Abramson Cancer Center for us to put in action. Those funds have supported by now 63 projects. And what's amazing is when we look at what happened to those projects and calculate additional funding, we know that the return on the investment is something in the range, depending on the year, something in the range of 6 to 9 fold. So these are really catalytic dollars and amazing for us. And we really, really thank the board and all the supporters for your confidence in us. It's a tumultuous time now with changes in federal funding. And as we anticipate adjusting to that, it's your ongoing support and your ever increased support that really matters so much right now. I want to remind everyone that on September 14th will be the 12th Breakthrough Challenge out as usual at the Daniel Boone Homestead. And so go ahead. It's not too early to mark your calendars and fix your bike up or whatever, however you want to participate. There are many ways. We're going to hear from the Buzz Cooper Scholars. These are the pilot award winners from the class of 2024. We have 5 presentations to go through. They're going to be quick, and I'll clarify, and then after all of them, we'll take your questions from the Q&A. You can put them in there. All 5 of our scholars this year, I think it's really important to point out, all 5 are assistant professors. So that's the first level of faculty where these types of dollars and this type of support matters absolutely the most. So again, thank you for participating. So without further ado, we'll jump in. We're not necessarily in alphabetical order, but we'll start with Dr. Zev Binder. And as we call up his slides, I'll just let everyone know that Dr. Binder is a research assistant professor. He's in the Department of Neurosurgery, and he and his colleagues have been working on any number of innovative ways to address new therapies for patients with glioblastoma multiforme, which I'm sure he'll describe. So Zev, take it away.
Thank you very much, Dr. Varnhut, for that very nice introduction. So I actually had the privilege to present to this group last year for an award that I received. Today, I'm actually presenting on behalf of a postdoc of mine, Megan Logan, who received this award.
That's our Hall of Fame.
Sorry. Megan unfortunately left my lab to go do a fellowship at the FDA. I am doing everything I can possible to lure her back because she did some fantastic work. So I'm going to briefly take you through the project that she worked on, which is in most basic terms, doing cell-loaded gels used to coat the GBM or glioblastoma tumor cavity. The technical title for it was Novel Porcine Brain-Derived Hydrogel Carrier for Intratumoral Administration of CAR T Cells in Post-Resection GBM. GBM or glioblastoma is the most common and lethal primary brain cancer in adults, primary meaning that it arises first in the brain as opposed to metastasizing from elsewhere in the body. It is an incredibly invasive disease, so at the time of diagnosis, there are already cells that have migrated away from the tumor bulk, and what that means is that the standard of care, which includes surgical resection, radiation therapy, and then chemotherapy, is non-curative because it doesn't really hunt down those individual cells that have migrated away. And with that, the median overall survival with a full scope of treatment now is still under 2 years. It's running at about 1.5 years, 16 to 18 months. And what you can see over here on this autopsy series, there's this tumor bulk here, which can be addressed by the surgery, radiation, and chemotherapy. But all these black dots that I'm highlighting with the red arrows here represent nests of tumor cells that have migrated away from the tumor bulk by the time of diagnosis. And those are obviously not captured by any of the standard of care treatment. So what are we at the Abramson Cancer Center trying to do to address this? And we really feel like immunotherapy or redirecting the patient's immune system offers a solution to this invasive nature. We have actually just completed our third trial. It's going to be published online on June 1st, which we're very excited about, using CAR T cells or chimeric antigen receptor T cells, where you take a patient's own T cells and you re-educate them to be able to find the tumor and target it, and then you put them back into the patient. But the standard approach for this, again, uses standard of care therapy with surgery, radiation, and chemotherapy. And then you go back and give the CAR T cells sometime after that. And we wondered if there was a way to take advantage of sort of the exposure of the tumor cavity during the time of surgery. I mean, literally, my neurosurgeon counterpart texts me at least once a month saying, I was just finishing a surgery wondering why I didn't have anything to administer right away. And so the overall thought of this project was that the tumor itself, the glioblastoma, is removed by the surgeon, but there are individual tumor cells that are left behind around the edges of the tumor cavity. So we take the opportunity of that exposure during the surgery to put in a hydrogel or a gel that will coat the interior of this cavity. And you could load it up with whatever you wanted. In our case, we're using these CAR T cells or redirected T cells, which would then be in close proximity to the remaining tumor cells and able to get into the tissue and eradicate the remaining disease left behind. So for this approach, Megan chose to use pig brain. Pig brain actually turns out to be incredibly similar to human brain in terms of its cellular and non-cellular components, as well as really its physical properties. So it'd be something that was sort of fitting into the existing infrastructure there. So she was able to get pig brain tissue from labs that were doing cardiac studies and didn't need the brain at the end of their study. She takes the pig brain tissue and she removes all the cells from it and washes it so that you have a sterile product that you can then remove the moisture from, lyophilize, and turn into really this freeze-dried powder. And you can then rehydrate the powder into a soluble solution that at room temperature actually becomes a hydrogel. And so you can see actually with this tube turned upside down that we're able to have a viscous enough material that it's able to stick. And this is actually very important because if you don't coat the cavity, if you put in just a liquid, it's not going to keep the cells in contact with the tissue that they need to invade into. And so you're not really going to get penetrance where you want it. So you want something that's sort of sticky enough to coat the cavity and really remain in proximity to the edge of the resection cavities. So she took this hydrogel, loaded it up with CAR T cells, and then using a mouse model, tested to see if she was getting a better effect than the traditionally approached method, which is where we inject the CAR T cells through the veins. We use an IV delivery. So these are histology images of mouse brains. And so what you can see in purple circled here are tumors. So this is a region of high cellularity, very, very dense tumor. This was our control, so no treatment whatsoever, the natural progression of the disease. This one actually received surgery only, so she had a model that was mimicking what happens to the patients. This tumor had been removed, but it wasn't removed in its entirety because it was invasive, and so it had regrown, and you can see again here the tumor bulk. This one actually was with the standard treatment, so using the standard treatment for CAR T cells. So this was the CAR T cells administered into the vein and allowed to circulate throughout the body, hopefully getting to the tumor. And while I'm not showing the extent of survival here because there was benefit, as we know this approach does work, the tumor still did regrow, and so you can see the bulk here. And this was with the hydrogel or decellularized extracellular matrix, as we call it, the DECM treatment, where the cells were implanted directly into the tumor cavity. So you can actually see here, this is the residual tumor cavity left over. And there's no significant tumor here. The treatment worked and the animal did not have any regrowth of its tumor. And if you actually go down to a cellular view, so this is immunofluorescence. And what we see here, the blue are just nuclei, the green represents the tumor itself, and the red are the T cells that we have injected in as a treatment. And you can see in this last panel here that there is a significant number of T cells that infiltrated into the tissue and very little of the tumor actually left behind because the T cells were in close proximity to the tumor and able to do actually what it was that they are intended to do and eradicate the tumor. So this approach has significant potential. As I said, it's something that can be done at the time of surgery when the bulk of the tumor has already been removed and you have easy access to it. And we know that these CAR T cells are an efficacious therapy with our current trial having some pretty exciting results. And we feel like this approach is only going to enhance that, given the sort of the direct administration of T cells to the cavity itself. And so Megan's work is now in submission for publication, but we're also using this as sort of a springboard to put forth a new application to the FDA for, it's not a new drug, but it's a new device, the hydrogel itself, to be able to actually use this into clinical trials and see if we can demonstrate these same effects on patients that we saw in the animal models. And so, of course, I have to extend a huge gesture of gratitude and thanks to the Breakthrough Challenge for really helping providing the funding for a lot of this pilot project work. And Megan, who, as I said, is down at the FDA, pretty good chance that we're going to be able to grab her back and have her continue on some of this very exciting work and take it to fruition. So, thank you very much.
That's great, Zev. It's a growing trend in immunotherapy to think about local delivery rather than systemic. This is in the field what we're seeing. The gel is inert. So why is that important?
Yeah, so the gel is going onto the residual tumor tissue, and there could be the chance that the tumor would actually prefer the environment that the gel is providing. So, for instance, tumors like very stiff matrices or environments, it helps them grab on and move around better. So, if the gel didn't match normal brain tissue, if it was too stiff, which is actually what you often find with a lot of commercially available products, it could encourage tumor growth, which is sort of the opposite of what we're looking for. And in addition, the brain does not respond well to inflammation. So while we are using the immune system to attack it, it's sort of very controlled. And if the hydrogel was not inert and stimulated a inflammatory response, that could also end up killing the patient. The brain swelling is a very, very dangerous condition. And so we have to be very careful with what we do, even in the context of tumors. So by having something that is inert and matches normal brain properties, it doesn't cause any benefit to the tumor.
Gotcha. Okay, we may catch you at the end for some more questions about that. Thanks, Zev. Sticking with immunology, and next up is Dr. Ahmed Diab. Dr. Diab is assistant professor in the Department of Otorhinolaryngology and also the Department of Cancer Biology. And we're excited to hear his work and progress on immunotherapy for patients with head and neck cancers.
Thank you so much, Dr. von der Heide. Good afternoon, everyone. Really a pleasure to be here today to talk to you about our work on head and neck cancer. I'm going to start with one of Dr. von der Heide's most favorite publications every year. It's the report from the Animal Cancer Society on the status of cancer in the nation. And one thing that we're very proud of as cancer researchers, that many cancers are on the decline in the country because of all the amazing work that is being done across the country. But some sign of concerns are these cancers shown here in red in terms of number of incidents that have been going up, and head and neck cancer consistently continues to be among those cancers that are increasing in numbers. Not only that the numbers of head and neck cancer patients in the country are increasing year after year, but they're also, these patients are dying from their cancers more often than many other cancer patients. And this highlights the need for better therapies than we have right now to help these patients and give them a lifeline. In the lab, we focus on a particular type of head and neck cancer that is driven by human papillomavirus infection. This virus accounts for over 5% of the global load of cancers. These cancers happen most commonly in the cervix. This is the one cancer that people usually associate with HPV infection. But over the last 20 years, we've come to appreciate that this virus also leads to oral cancer or head and neck cancer, and it's mostly in men, more so than in women. And we really don't know much about why this is the case, but it is basically the upcoming epidemic. We know quite a bit about how HPV as a virus causes cancer. We think it has to do with how the virus damages the DNA inside our cells. Most people who are adults and sexually active have been exposed to one type of HPV at some point in their life. Most people clear the infection, but in a small fraction of people who have persistent infection eventually end up getting cancer. And we don't know why certain people end up having persistent infection and why among those with persistent infection, an even small fraction eventually get cancer. But answering these questions is really important to understand how the disease happened and come up with better therapies. We speak about head and neck cancer in general as a big term, but in reality, when HPV causes cancer, it's mostly in what we call the oropharynx. It is the base of the tongue, the back of the throat, and the tonsil. These are relatively immune-rich organs, as I will explain. That means they have a lot of immune cells. But the response to immunotherapy, paradoxically, is not any better than any other solid tumor. It's the usual 20 to 25% of patients who respond to immunotherapy. And it is still not the standard of care for this cancer, although results from this year's American Association for Cancer Research suggest that maybe we're moving forward towards immunotherapy being a standard of care for head and neck cancer patients in general. Now, the standard is chemotherapy, radiation, and surgery. It is a pretty brutal standard of care for a subset of patients who have HPV who tend to respond very favorably to this treatment, but then they have to live with lifelong toxicities associated with this excessive or aggressive therapy regimen. Many of these patients who are in their 40s and their 50s have to live with loss of speech, loss of hearing, inability to swallow, and disfiguration for the face. It's the cancer, the second most cancer after lung cancer in terms of suicide rates. So we really need to help those patients. Again, a lot of problems for immunotherapy, particularly in this cancer, where 90% of this cancer with HPV arises in the tonsil, an actual immune defense organ that is filled with immune cells and should be primed to respond to immunotherapy. Yet if 1 in 5 patients are only responding, how can we do better? We need to understand how the cancer responds to immunotherapy and why only 20% of patients respond. But we really don't have a lot of models and clinically relevant models to study the response of patients to immunotherapy. We are very lucky here at Penn. In the Abramson Cancer Center, we see a lot of HPV positive head and neck cancer patients, almost more than any other cancer center in the country, where they're being treated with robotic surgery that is minimally invasive. But what is even more cool about this surgery platform is it gives us access to fresh resected patient tumors that we can take to the lab, slice and culture in the lab, and apply our new immunotherapies to these cancer patient tumors that we have in the lab and see how they respond to the therapies, and then go back and ask if these patients responded or didn't respond to this novel immunotherapy. What is it about these tumors that primes them for response or lack thereof? So this was a very exciting project. We wanted to make sure that this approach is actually working in our hands. So we get the tumors from the OR. It's about a 10-minute walk to the lab. We slice them and culture them in the lab. And we treat them with a cocktail of chemicals that we know is going to activate the T cells within these tumor cultures. These are the immune cells that know how to fight cancer and are primed to fight cancer. And so when we give them these chemicals shown here in red, we know that they're going to get activated across the board. And this is what we see. So I'm showing here data from about 20 patients that we took their tumors, cultured them ex vivo, treated them with an activation chemical cocktail, and we see their T cells are more active and they're more antigen experienced. It shows like these tumor infiltrating CD8 T cells have seen tumor antigen and have reacted to it, and we can read that out pretty robustly in the lab. Now we'll go into the exciting part. We can actually treat these tumor cultures in parallel with an experimental, not necessarily an experimental drug at this point, but this is an approved immunotherapy. This is the Keytruda that cancer patients take. And so we treat the tumor slices ex vivo with the drug, and we see that now we can stratify our cancer patient tumors into those that respond by activating their CD8 T cells, so they're more functional. On the other hand, we have quite a few of these patients where we see no responses to the drug. And now that we start to see this dichotomy in response, we can take these tumors and study them further and try to find correlations between the tumors that respond and their biology and tumors that do not respond in their biology in order to be able to personalize this kind of therapy in the future and better help our patients. This is an ongoing work that is a close collaboration with the lab of Joan Wary. I'm really proud of the group that we have in the lab that is helping me get this work and better help our patients. Grateful to the funding sources and to you for your attention. I'd be happy to take any questions there.
Thanks, Ahmed. That's really cool to have this laboratory method of the whole tumor, not just the tumor cells, but other cells as well. You're telling us about the T cells. Can you probe for other immune components in these slice cultures?
Absolutely. This is just the beginning, and we decided to look at the T cells because this is where the most successful immunotherapies are right now, but this platform allows us to look at every single compartment in the microenvironment, and not just the immune cells or the tumor cells, but even stromal cells as well. So we're really excited about this.
Yeah, this is great. So, okay, stay with us. We'll revisit perhaps later, Ahmed. We'll keep moving on our third presentation. This is from Dr. Andrew Zart. Andrew is an assistant professor of chemistry, so not in the School of Medicine, but on another part of Penn's campus. Of course, the Abramson Cancer Center is across all of Penn, not just the School of Medicine. And Andrew's going to tell us about taking machine learning, some people call that AI, to help optimize biological chemistry to find new drug targets. Andrew?
Hi, thanks for the introduction. Can everyone hear me and see my screen?
We can see it. It's not in the presenter mode just yet.
All right, I think there's a lag. Is it now?
There you go. Great. Thanks.
All right. Yeah, thanks for having me. Yeah, I'm coming from the Department of Chemistry, and I'm going to tell you a little bit about how we're trying to use machine learning and robotics to automate drug discovery. And the specific area that we're working in right now is related to this problem that over 80% of disease-related proteins are considered undruggable. So what that means is that the traditional mode of action for a lot of conventional therapeutics is to essentially stick really, really effectively to a protein and somehow change its function. So if we're incapable of performing that action, then we are incapable of treating diseases caused by those proteins. So one thing in the field that has been done recently, one strategy that people have worked on, is to use targeted protein degradation as a technique for kind of using the cell's own machinery in order to target these previously undruggable proteins. So the one tool that people use to do this is by developing these molecules called PROTACs. So PROTACs are they're called heterobifunctional molecules. So what that means is there's three components, two that kind of does the work and one that brings it together. So how this works is there will be a target protein that's causing some disease. There will be a warhead, which is indicated by this kind of pink triangle, that will stick to that target protein. It doesn't need to stick very hard. It just needs to stick hard enough to be associated. And then that warhead is going to be bound through a linker to another part of the molecule that will recruit your cell's machinery that can target proteins for degradation. So what this essentially is doing is putting a flag on the target protein, signaling to your body that we need to degrade this protein. So this is the area that we're interested in working in. And some of the challenges with this is a lot of the conventional wisdom around small molecule drug development doesn't really apply to PROTACs. And they're quite challenging to make. So those are two of our motivations. And these have been demonstrated to be effective therapeutics. There are currently 2 PROTACs in phase 3 clinical trials, one of which has been fast-tracked as a treatment for breast cancer. So our approach First involves mining databases of building blocks, essentially, so we can, in the computer, construct every conceivable PROTAC that could be made for a target application. Then we devised a new solid phase synthesis approach. So this is essentially developing new chemistry that's going to allow us to make these things in an automated fashion. And then we're going to construct what I think of as an intelligent automated platform to be kind of like a robotic collaborator for the chemist. And then our workflow would be, first computationally designing, our database or synthetic targets, passing that off to an automated platform, which will make the targets. And then we hand those over to our collaborators in the medical school who collect the data. And then this can be an iterative process where we then use machine learning to guide the next round of synthetic targets. So this is our target molecule for our current case study. The important parts to note about this is I've just tried to color code them so they map on. So this kind of pink part of the molecule is what sticks to the target protein. This blue part is what recruits your cell's machinery. And what we're interested in is engineering this piece that binds them together. So we've already identified good subunits for sticking to the target protein and to the E3 ligase. But this linker can change some of the biological properties, such as, for example, how fast is it excreted by your body, right? So that part needs some engineering for this molecule to be effective. So what we do is we say, all right, we want to keep these two subunits because we know that they're going to be useful. And then we can say, all right, every hypothetical molecule that we can use to build a linker and bring these two units together, we're going to construct using pretty well-established chemistry. So that gives us, in our current iteration, about 300,000 possible lead compounds that we know we can make from commercially available starting materials and are amenable to automated synthesis. So this ensures everything is makeable. But another aspect of our approach is that we kind of build these things from right to left. So the part that targets the target protein is the last part to go on. This is an intentional design choice because hypothetically we can then build up a large library of the linker plus E3 ligase units. So if we ever want to target different types of cancers in the future, all we need to do is swap out the warhead and we'll be creating a data set that's going to be targeting a new protein. So in the first step of our workflow, I've mentioned we build this 300,000 member library. This is what it looks like. All these gray points are hypothetical therapeutics. All the blue points are ones that are known in the literature. There's likely more than this. They're probably just not in the public domain. Either way, you can see that the types of molecules accessible to our platform is much larger than the types of molecules that has been synthesized to date. So our first step is going to be to just explore this space. We'd use unsupervised learning for this. This just means we're going to use math to pick the most different set of molecules that we can possibly make. We then pass this to an automated platform. So because we made these molecules with the synthetic route in mind, we should know the synthetic route and then be able to pass this as a prompt to a large language model. That large language model is going to sit on top of the robotic platform, and the platform will be able to reconfigure itself in order to do the physical manipulations necessary to make the molecules. And then the synthesis is going to be executed by the platform. We then take those molecules and we bring them to our collaborators over at the medical school. They test them in a high throughput biological assay. And then we use those targets to train a machine learning model and do what's called an active learning workflow. So we just essentially turn molecules into numbers, relate those numbers to the properties that we're trying to optimize. And this can be an iterative workflow until we identify a small set of candidates that we want to move forward to animal trials. So this is essentially where we're at right now, is we're working on turning this crank. I'd say all of these individual parts are worked out, and at this point we're just putting them all together. And I want to take a second to talk about the people doing the work. So these are our collaborators in the medical school and the Sellmeyer lab. This group is my group working on this. Perk does the chemistry, Scott and David do the robots. And I'd like to thank you guys because this is probably not an area we would have gotten into without this support.
Yeah, that's a really good point. Thanks. Great presentation, Andrew. It's so exciting. I heard you call it turning the crank. I guess my question would be, what would it take, or what are the challenges in just getting to a point where you can turn that crank faster and faster and just increase the scale of this discovery?
Right. Yeah. So one challenge is that not all chemistry is amenable to automation. So there's a lot of physical manipulations that are difficult that we need to engineer new solutions for. It also requires a lot of chemicals, and being able to make a robot that can access, hundreds of different molecules is challenging. And the purification is really difficult to scale. And that's one thing I didn't highlight, but our automated synthesis strategy will pretty much grow the therapeutic off of a bead, and then we can just cut it off so it automates the purification. So generalizing that is also going to be a challenge.
Great. Okay, Andrew, I have more questions, but we'll hear from our last two speakers, and others may have questions. You can put those in the chat. Anyone listening, we'll get to your questions as best we can. Next up is Dr. Roger Kim. Dr. Kim is assistant professor in the Department of Medicine, and he's in the Division of Pulmonary Allergy and Critical Care. He's interested in lung cancer screening, and so we'll turn it over to Roger.
Thanks so much, Dr. Van der Heide, for that nice introduction. And thank you to everyone on this call for making this research possible. So as Dr. Van der Heide mentioned, I'm an assistant professor of medicine. I'm an interventional pulmonologist by clinical training and also a health services researcher. And a lot of my work has really been geared towards optimizing the lung cancer diagnostic process, and encompassed within that is, lung cancer screening optimization, and then also pulmonary nodule evaluation and management optimization. And so the work today I'm going to be talking to you all about is what I've dubbed the CANE study, Clinicians' Approaches to Pulmonary Nodule Evaluation. These are my funding sources, in addition to the very generous funding through this grant mechanism. So just by means of introduction, what is a pulmonary nodule? So pulmonary nodules are incredibly common. We know that at least 2 million patients are diagnosed incidentally with pulmonary nodules each year, and at least approximately 15 million Americans each year are eligible for lung cancer screening with low-dose CAT scan of the chest, which at times can identify pulmonary nodules, which are these densities that you can see on the right side of the screen that may or may not represent early stage lung cancer. Unfortunately, less than 10% of all detected pulmonary nodules actually end up representing lung cancer. And so it really is our responsibility as clinicians to very carefully determine what the individual risk of a given patient that we're seeing in clinic might be, what their risk of cancer might actually be, integrate their preferences and their goals of care in addition to, seeing where they are in life and having a shared decision-making conversation to actually decide what to do next for any given pulmonary nodule. And at the end of the day, the decision that we need to make is a binary choice. So as you can see on the left side of the bottom of the screen here, one option is just to keep a very close eye on the pulmonary nodule by obtaining serial surveillance imaging, basically to try to understand its trajectory over time. Understanding that a cancer will continue to grow in size, whereas a benign nodule will not grow or sometimes even disappear. On the other side, we can choose to do more aggressive management with either a biopsy or empiric treatment with surgical resection or empiric radiation therapy if we think that the risk of cancer is high enough that we don't want to wait. Understanding that if we were to wait a couple months, sometimes that cancer can actually spread and increase in stage and potentially spread throughout the rest of the body. The problem with this is, the only way to definitively know what the diagnosis for any given pulmonary nodule is is to ultimately biopsy it, as that is the only way in modern medicine that we have of understanding what something is pathologically. And there's unfortunately risks associated even with the most advanced biopsy techniques that we have. And so there's this very careful risk benefit management decision-making that must go into this shared decision-making process that is quite complex. And so the goal of this study was twofold. It was an exploratory sequential mixed methods approach, which is a fancy way of saying that we interviewed clinicians around the country to try to figure out how they go about actually doing this very complex decision-making. I didn't go into a lot of the details, but there are a number of different tools that are in existence that help clinicians to make this kind of challenging decision making. And we were really interested in understanding how these tools are being used, how practice patterns may actually differ from clinician to clinician, from healthcare institution to healthcare institution, and regionally across the country. So that was our aim one. And then we're planning on using that data in aim two to actually develop a nationwide survey that we're going to administer to quantify some of those patterns that we identified in aim one. So far, I've completed aim one, the interview component of the study, and we're currently in the process of designing the national survey. So we ended up interviewing 40 different clinicians that are currently actively practicing. We had a nice distribution of age, sex, gender, location across the country, and also specialty. So just to name a few highlights here that you can see on the screen as far as the demographics of the clinicians we interviewed, median age was 40 years, 55% of folks were female. And we had predominantly white clinicians, 75% white clinicians. We had a nice mixture of general pulmonologists, interventional pulmonologists, and thoracic surgeons to try to get a comprehensive picture of what folks are doing across the country. And we also had a variety of experience. So attending physicians, fellow physicians that are still in training but almost completing their training, and then also advanced practice providers, recognizing that a large bulk of the healthcare administered in the United States is actually via APPs or advanced practice providers. Most folks did practice in an academic setting, 78% to be exact, and most practice in an urban setting. And about half of clinicians that we interviewed practice within a dedicated pulmonary nodule clinic. So in order to analyze the interview transcript data that we were able to generate, and I should mention, this is to date the most comprehensive interview that has ever been done to assess the current pulmonary nodule evaluation and management practice landscape across the country. We looked at different themes that we decided on before we even designed the interview guide. And so these were really trying to get at the different factors, multi-level factors that could potentially influence nodule management decision-making. These range all the way at the kind of center here to the characteristics of the pulmonary nodule itself on imaging, moving up to the clinicians and patients, so the two parties, so to speak, that are actually engaging in this shared decision-making that needs to occur in order to decide what to do next. Encompassed within that were clinicians' opinions and perspectives on some of those different risk assessment tools that I mentioned before, and then also how to integrate patient preferences into this complex decision-making. And then zooming out a little further in the inner context, which is really what we use to describe institutional practice patterns. So every different healthcare institution has a different approach to, frankly, funding some of the resources that need to go into making this complex decision-making, and some of the different multiple different specialties that are involved in this decision making. And then the outer context, which really we defined as sort of the 30,000-foot view, the existing clinical guidelines, what active research is going on, and sort of the heterogeneity in standardization and resources available globally. So these are, I tried to distill my best to distill some of the comprehensive data that we are able to obtain from the study, but I tried to distill this down into some of the predominant themes that arose from each of those different larger domains that I just went through. So within pulmonary nodule factors, we found that most clinicians highly valued personal review of the radiographic images that were obtained of the pulmonary nodules, and was actually really the most important factor for determining cancer risk assessment. Regarding clinician factors, interestingly, we found that most clinicians do not believe that many of the multitude of commercially available risk assessment tools that are out there and have been in existence for the past 30 years actually influence medical decision making, regardless of their perceptions of clinical impact and variable approaches to diagnostic workup as well for intermediate to high risk nodules, meaning how to go about determining whether or not a given pulmonary nodule is cancer or not. Among patient factors, we found that patient preferences, life expectancy, and physical fitness strongly impacted clinical decisions via shared decision-making process. And then within the inner context, we found that many clinicians highly value a multidisciplinary, centralized approach to pulmonary nodule care, and also cited a lack of diagnostic efficiency and standardization as barriers to optimal care. And then within the outer context, we found that clinicians have widely divergent opinions about published clinical guidelines, ranging from, frankly, strict adherence to intentional disregard. So in conclusion, we found that there was a high variability in pulmonary nodule evaluation and management practices among the clinicians that we interviewed. And this, in my opinion, really indicates a need for improved diagnostic accuracy, efficiency, and standardization in order to make the best decisions for our patients and optimize the lung cancer diagnostic process. And we hope that our national survey that we're currently in the process of designing and implementing will help to quantify some of these results. Future goals of mine are to try to implement some of this data that we've been able to accrue into developing an intervention within the context of a clinical trial to try to improve our diagnostic process. I work with a wonderful team of researchers in the mixed method space, along with my two mentors, Drs. Rendell and Vishani, and I'd be happy to take any questions.
Thanks, Roger. Well, just one thing quick. You said this will set the stage. First of all, it's I don't know what it is, impressive or something more than that about the variability in physicians looking at the same CAT scan, how they might approach an interpretation and what to tell a patient. So that's something to think about. But what would be the intervention or the clinical trial? Like, what research question do you think you could address with this tool?
Yeah, thanks for the question, Dr. Von der Heide. So I'm actually in the process of running the first ever pragmatic clinical trial assessing the only commercially available artificial intelligence, computer-aided diagnosis, radiomics-based tool for pulmonary nodule risk assessment right now to see if there is any kind of moving of the needle, so to speak, in the quality of medical decision making. And so I'm hoping that the kind of results that we're able to generate from that preliminary or from that pilot trial will then integrating with all the information we just gained from this qualitative data, we're hoping to integrate all that information together to try to design an even more effective intervention to test on a multi-center scale eventually. But I think there's basically unlimited room for opportunity for improvement based on the preliminary data we were able to obtain from this study.
That approach, and then what we heard from Andrew about using machine learning and other types of AI. That's now 2 examples out of 4 presentations, so it tells us this new tool. Okay, so hang tight, Roger. We have one more presentation. This is from Maria Basel, who I think has left her clinic. Yes, and here you are. You finished. Good to see you. Assistant professor of medicine in the same division, right? Pulmonary critical care, allergy critical care, and you're going to talk to us again about an issue in lung cancer, a biological issue. I'll let you. We are getting some questions in the chat. We can go to a few of you are asking more about the effect of the NIH funding and we can talk more about that. Obviously, we're watching it very carefully, but I think our overall approach is to do what we're doing today, which is keep focused on the science, keep pointing out the value of this work, and the real crucial need to fund research, and particularly make sure our young investigators continue with their support. And so that's why it's been so great to partner with BC and hear from these assistant professors so far today. Maria, you're back. We can see your slides. You ready
Thank
to
you.
go?
The right version of the slides, not the presentation.
You're
map.
on. You're
You
on
see,
sort
yeah.
of the.
Marie, doctor, if you would go to the top left, you see like a couple. Yeah, you got it. Thank you so much.
Okay,
All
great.
right, thanks, guys.
Thanks.
Sorry for that technical snafu. As Dr. Bonner had mentioned, I just ran here from clinic across campus. So like Roger, I am also a pulmonary critical care doctor, and I'm going to talk to you about something somewhat related, actually, but quite a different approach, which is looking at the origins of human lung cancer, sort of from this eye of lung cancer screening at the end. So how did I get interested in this field, and why do I think this is such an interesting concept for our laboratory in particular to follow up? And it's really because my interest started as an interest in chronic obstructive pulmonary disease, or COPD. And I think most people probably recognize that a massive risk factor for the development of lung cancer, as well as for the development of COPD, is cigarette smoke. It's not the only risk factor, but it's an important one. And in some ways, this idea of going from a healthy lung to COPD to malignancy is sort of on a spectrum. And I became very fascinated with COPD pretty early on in my career. And I decided in my postdoc and as I started my own laboratory to really focus on the cellular mechanisms of injury in COPD. So I'm a trained cell and developmental biologist with a background in stem cell biology and developmental biology. And I became really interested in how does this injury affect the cell types of the lung, and how do the cells respond to these injuries that humans are encountering that cause these diseases. And this is actually somewhat tricky to study because it really focuses on this region of the lung that I've diagrammed here in orange. So I'm showing you sort of a simple schematic of a mouse lung on the left and a human lung on the right. And you can see that there's this entire anatomical region in here in orange. These are what's known as the respiratory airways. And these have probably evolved over time to handle the fact that we have such a larger volume of gas exchange in larger mammals. But we're really going back to the 1950s and really terminating with this seminal study from British Columbia in 2018 said, actually this human lung is the first site of injury in COPD. And the problem with that is that the cells of this part of the lung, until very recently, were not actually defined. We didn't know what cells existed here because all of our work in lung developmental biology and injury and regeneration had come from mice. And so my lab first worked on what are the cell types that exist in this lung. And we identified a population of secretory cells, which means cells that produce a lot of proteins, that we called respiratory airway secretory cells, or RASC cells. And we were able to show, using a combination of in vitro and ex vivo cell culture-based model systems, that these cells seem to have the ability to act as a human lung stem cell. So again, these are cells that are not found in our animal models, but we were able to show that they could self-renew or regenerate themselves, and they could give rise to these cells I'm showing here in pink, which are alveolar type 2 cells, which the most important thing to know about these cells is that they are themselves a really important cell for keeping the gas exchange units of the lung happy and healthy. But we then went on to show something very interesting, I think, which is that in injury from cigarette smoke in humans or in large animal models, the progenitor function of this cell is actually disrupted. And it can't make as efficiently these alveolar type 2 cells, but rather it forms these sort of aberrant injury-related cells. And we've seen this across now many injuries and many diseases, including cigarette smoke injury and in COPD. So what this suggests is that the clonal pattern of injury, how stem cells respond in these injuries, is actually disrupted in human lungs. So this really gets to the question of what do we know and how can we study these stem cell responses to understand how disease develops and eventually how malignancy develops. Because normal lungs have their own clonal response, disease and injury has a clonal response as well, and presumably it's these clonal responses that eventually go awry in malignancy. And this really gets back to a point that I think a lot about now, which is that the cell that can cause human lung cancer is not really known. We've shown in mice that we can cause lung cancer from a lot of different cells, but what cells in humans are capable of giving rise to malignancy? So to tackle that, we had to be able to start to tackle this question of identifying clonal relationships in patients. So the models we did when we identified these cells and showed their stem cell function were ex vivo model systems. But can we identify clonal relationships and say cells are actually clonally related in humans? And this is actually really hard to do, right? So in mice, we do this with genetic tools and we create marks in the DNA so we can track related populations. So how can we do that in human tissue? So we turned to sort of a genetic trick called mitochondrial heteroplasmy, which is just a really sort of complicated term that says every cell in the body has many, many, many mitochondria. You probably learned about mitochondria in school as the powerhouse of the cell. The function here is not critical, but every mitochondria has its own DNA. And that DNA is relatively prone to mutation. And so as you can see in this diagram below, this sort of schema here, as cells divide, they give their daughter cells, their progeny cells, copies of their mitochondria. So cells that are more similarly related will share the same DNA patterns in their mitochondrial DNA. And this isn't necessarily a new concept. People have been thinking about this a lot and using this, for example, in cell culture and cell lines. But we wanted to ask the question, can we use mitochondrial heteroplasmy to actually identify clones in patients, in the human lung? And what we were able to do, in large part thanks to the support of this grant, was we were able to extend this technology into primary human tissue. So I run a human lung tissue bank here, which handles a couple hundred lungs a year from both patients with disease and normal lungs. And we've been collaborating with Sunil to expand this into malignancy and pre-malignant lesions. And what I'm showing you here is an example of this kind of data. So each dot here represents an individual cell. This is a single cell RNA sequencing experiment. It doesn't necessarily matter what each dot is, but we've been able to identify that it's an individual cell from an individual patient. And because we have deep information on each cell, we can identify it as a cell type. So you can see these cells that I mentioned earlier, the RAS cells that we identified, and the alveolar type 2 cells. And we wanted to ask, in normal human lung, can we even identify these clones? And indeed, we were able to show that we can. So for example, we were able to show that there are clones identified by mitochondrial relatedness of alveolar type 2 cells that have expanded. And perhaps most interestingly for us, we were able to identify these patterns of shared RAS cells and alveolar type 2 cells. So mitochondrial patterns that are shared across these cell types, identifying that these cells share a common progenitor or gave rise to one another over the injury response or the development of the human lung. So we are continuing to pursue this work in patients with COPD and other lung diseases, and also in early malignancy. And the goal here is to not just identify the patterns, but to be able to use the transcriptomic data, so the deep RNA information we have from every individual cell, to identify gene signatures from clones from normal patients, disease patients, as well as malignancy patients. And so why would we want to do that? Well, we would want to do that because that might allow us to identify molecular signatures of these in-human, in-patient clonal responses and identify how they change between injury and disease and in malignancy. And the eventual goal here is molecular risk stratification, right? So Roger told us so nicely about some of the challenges of screening lung nodules visually. And all of our patients who get lung cancer screening have the same sort of epidemiological risk, right? I'm a cell biologist, but I at least know enough about the kind of work that Roger does to say that. And so what if we could sort these patients now by their actual molecular signatures of their injury responses into groups that, for example, had almost no risk of progressing to cancer based on their clonal responses, compared to groups who had clonal responses that looked a lot like they were going to progress. That could help us really shift the needle on how we cohort our patients and think about establishing surveillance programs for our patients in the future. And so with that, I will thank the people who did the work. This is our lab, both in our formal picture and what we look like in real life. And I would be happy to take any questions. Thank you so much.
Thanks, Maria. Great to see scientists in real life. Do you think, just to think of the possibilities, do you think this could be a tool to guide development of new therapies, say for lung cancer?
Yeah, I didn't talk about that here, but one of the advantages of the way we've approached this in this sort of unbiased way, but still very molecularly oriented, is we will get a ton of information on the programs that these cells turn on when they are early in their development, advanced malignancy, injury responses. And then we have the ability to go back and test those gene signatures and these transcriptional and other regulation patterns that get turned on, which could give us a whole new paradigm for how we would think about screening and developing new drugs for lung cancer.
Yeah, great. Super exciting. All cells come from another cell. That's the way it goes.
I made a career on that sentence. Yeah.
Yeah, I read that sentence from Peter Knoll, and he wrote something. I just happened to be reading it. He was the first cancer center director. Don't ask me why I was reading it this weekend, but that's what he said once, quoting someone else. We're approaching time, and I want to be sure we ask Bill Barber, who's vice chair of the Breakthrough Challenge Board, to have a few comments. Bill, are you there?
Okay, I'm here.
Great.
And
Wait a minute, you went back on mute.
okay, how is that?
Good.
Okay, thanks to everyone on this call. You're either here as a patient, a clinician, a donor, a sponsor, a writer, a volunteer that wants to improve cancer survivorship. And indeed, many of you are survivors. And that's what our board is most passionate about, to ultimately improve survivorship, and especially through the catalytic research projects that we've just watched. And thanks, Dr. von der Heide, for you and your excellent team, from the professors and researchers here at the Abramson Cancer Center to the on-site medical staff that you provide at the event to help us with any medical needs. And a special thanks I want to give to Carolyn Brown, who partners with our board, who works for Bob, and coordinates our event from within Penn. Thank you so much, Carolyn. Our 2025 event, as Dr. von der Heide mentioned, will be September 14th. That's a Sunday at the Daniel Boone Homestead. And this is the centerpiece of our rider experience in Berks County. The roads out there in the Ole Valley, they truly rival, in our opinion, the roads and vistas you'll find in Europe. So it's a very special ride experience, and a great community afterwards to celebrate the ride afterwards. We opened our registration on May 1st, 5 days ago, and we're on a great trajectory so far with our registrations and our donations. And we do have an early bird discount available until June 1st, so please take advantage of that. And thank you to the sponsors that you see on the chart. For our 2025 sponsors, we're adding sponsors and continuing to build sponsorship. And I just want to add my thanks to Dr. von der Heide's thanks to the Zent Family Foundation, especially to Chuck Zent, for their involvement over these 12 years. We simply couldn't be at nearly $3 million without their instrumental involvement. So Dr. von der Heide, we're looking forward to funding the next round of Dr. Buzz Cooper Scholars through our 2025 Breakthrough Challenge for your 2026 scholars.
Well, Bill, we're looking forward to that too. And with your all's help, we'll be able to do it. Thanks for that great information, Bill, and your always presence at the event and encouragement, particularly getting me to complete the course. I think the most important thing we'll say for now, beyond those thank yous, is September 14th. September 14th is the date when it will all happen again this year. So until then, we look forward to seeing you and really appreciate all the support and joining us this afternoon. Have a great day.